Welcome to the course. This is your introductory lecture, presentation, whatever you want to call it. So, what is pharmacology itself? Well, it's the study of drugs, study of medications, and the safe administration of those medications. So, study of drugs, study of medications. Every medication has actions. We're going to look into the actions of those medications and the effects they have on our body. And those medications, we can get them over the counter, or they might be their prescription. So we can only get them via prescription. And then we need to make sure that we have a safe administration of those medications. So what's the right dose? What's the correct route of administration? What are the indications that tells us that we should be giving this medication? What are some side effects that we should expect? What are some adverse reactions that we're like, oh no, oh crap, all right? But we can react to and treat them. Maybe we have medications with interactions between them. So we give two medications together. There are some interactions that we need to be careful of, and then contraindications. These circumstances in which maybe the medication is indicated that we give it, but there's this contraindication present, and we can't give it because of this contraindication. We shouldn't give it because of this contraindication. And then, when these interventions, when are we giving these medications? So this is kind of what we're going to be talking about throughout the semester and just pharmacology as a whole. We have a number of key terms to define and just kind of keep in our mind. So a drug, a medication, is any substance that's used to treat, cure, diagnose, prevent a disease or a condition. So this external thing that goes into our body. We have chemical names for these drugs, and that is a very precise description of that drug's chemical composition. We've got a generic name for that medication, which is an official name listed in the pharmacopoeia, and that's like diphenhydramine. We've got a trade name that's given by a private company that markets this drug, like Benadryl. Then for that drug, let's say Benadryl or diphenhydramine, we have some indication for that medication. So that tells us that we should be giving this medication. So without an indication, I'm not going to be giving Benadryl. But if I see an indication, like an allergic reaction, I'm going to give Benadryl. Then we have contraindications. Even though I see an indication, there might be something that says, whoop, wait, time out, let's not give this drug if they're contraindicated. So I have an indication for giving Benadryl, but a contraindication might be that my patient is allergic to Benadryl. So even though it's indicated, given my patient's symptoms and presentation, my patient is allergic to this medication, I probably shouldn't be giving it. All right, so I've got my medication, I've got my indication, I've given it, and maybe something happens. So maybe an adverse reaction happens. And an adverse reaction is this undesirable, unwanted consequence. It's kind of a big deal. An adverse reaction is kind of rare, it's unforeseen, it's kind of this big thing. It's always unintended, always harmful, even with the correct dose of this medication. So I've given Benadryl, I've given the correct dose of Benadryl, and then my patient goes into cardiac arrest, and like, oh no, crap, that's rare for my patient to go into cardiac arrest after giving Benadryl. It's unforeseen because I certainly don't expect my patient to go into cardiac arrest when giving just Benadryl. So then cardiac arrest is harmful and unintended. I didn't mean to do that, and it's harmful because it's cardiac arrest, right? So that's your adverse reaction. Compare that to a side effect. Side effect is kind of this extension. It's it's not a great thing. A side effect's not like a comfortable thing, but we know it's coming. We know it's going to happen. So, side effect of Benadryl, it's going to make you a little sleepy. That's a side effect. We know it's going to happen. It's not super harmful. It's not unforeseen. We know it's going to happen. It's not a big deal. So, a side effect, not a big deal. We know it's going to happen, but it's kind of this like side thing of the medication we give. The adverse reaction is this like big, unforeseen, oh crap, thing that happens. Let's cover a few more terms. We've got pharmacokinetics. Pharmacokinetics is, you've got this medication, and what happens biologically, what happens, uptake, distribution, binding, elimination. So all the pharmacokinetics. So how does this work within your body? Then we've got pharmacodynamics. What happens? What does the drug do to your body? So pharmacokinetics, what is your body doing to the drug? Pharmacodynamics, what is your drug doing to your body? And kind of continuing on that line, we've got receptors. So a medication might bind to a receptor, might block a receptor. So a receptor is this like site in which a drug interacts. Kind of endogenous substances interact, and we can tickle it, we can tickle that receptor and stimulate it, or we can block that receptor, so it can't be stimulated. So we've got receptor sites. We'll really dig into that later on in the semester. Also, let's talk about half-life. So every medication has a half-life, and the half-life is the time required for the amount of that medication in your body to be reduced by half. And that's kind of a constant. So if I have a 10-minute half-life for a medication, in 10 minutes, the drug I just gave, half of it is going to be eliminated, metabolized, and just non-functional. So the longer the half-life, the longer it stays in your body. The shorter the half-life, the shorter duration it has to act within your body. Okay, you're tired of all these key terms, but one more. Stay with me. Bioavailability. So bioavailability is kind of the percentage amount of that active drug available to reach its target. So bioavailability, if I give a drug that I want to affect the heart, how much of it is available to actually act upon the heart? And that's your bioavailability. Okay, you haven't given up on me quite yet. Okay, that's a good thing. So let's talk about some medication sources, some drug sources. So we've gone through just like our terminology, our key terms. So let's talk about some actual sources of medications. We've got plants, we've got animals and humans, we've got minerals, we've got synthetic, completely lab-derived medications. So plants, just a few examples of these. Digitalis, colchicine, quinine. These are plant-based drugs. They're synthesized from natural plants, which is why we kind of get in a tizzy when we talk about the rainforest, the Amazon is being cut down because all these plants are being destroyed, and we derive a lot of medications from plants. Animals and humans, well, insulin. Insulin derived from animals. Insulin derived from humans, right? So insulin originally derived from porcine. It was porcine insulin from pigs. Now we can derive insulin from humans, synthesize it from humans. We've got plasma. We've got packed red blood cells. We've got blood products directly from humans. Those are medications. Those are drugs. There's just something that we're giving to someone else. So animals and humans we can derive medications from. Same with minerals, like iron. You take iron supplements. You can take iodine, Epsom salt. I'm sure you've seen that, right? Magnesium sulfate. We have all of these mineral-derived medications that aid and kind of supplement our electrolytes normally in our body. And then these completely synthetic substances like fentanyl. So fentanyl is a completely synthetic substance. It's a synthetic opioid. So molecularly, it kind of looks like morphine, but it's completely synthetic, completely lab-derived. So morphine comes from a plant, right? It comes from that poppy plant. But fentanyl looks like it, acts like it, gets the same effects from it, but completely lab derived. Of all these medications, we're going to introduce another couple terms. One of that is this therapeutic drug range. And, this therapeutic drug range, this blue area, this is the area we want to be in. So I give a medication, and the drug concentration in my blood here on the y-axis goes up and up and up and peaks at some point, right? And here's this half-life. Here's this kind of area of action. And I want to be in this, I want this peak to be in this blue area, this therapeutic drug range, right? So, onset of action, I get this peak, and then we kind of terminate this action. And the bottom of this blue area is a minimal amount needed in my body to produce some effect. The top of this is a maximal concentration that is safe. And in this kind of gray, pinkish, salmon colored area is my toxic range. So if I go into this range, we're doing some bad things, right? We don't want to be in there, and we don't want to be in this kind of yellowish range either, because we're not going to get any effect. We want to be in this blue range because we want this therapeutic effect. Now, if we take that blue area and we shrink it down and we pull this pink area down, we pull this yellow area up, then we get what we call this narrow therapeutic range. This narrow therapeutic range, if we shrink down that blue area, is dangerous because we can go toxic very easily or we can underdose very easily. Typically, we're more concerned about the overdose than we are concerned about the underdose. So we're concerned about going toxic. So if we have a narrow therapeutic index, here are some drugs, just kind of keep in the back of your head. We'll kind of hit these one by one as we go on through the semester, but things like digoxin and levothyroxine and phenytoin and warfarin. These have a very narrow therapeutic index, and they need to be monitored. Your patients on these drugs need to be monitored to make sure that we're not going over or under that therapeutic range. Okay, so now we have our drugs, we have our medications. We know what's going to happen. We have our therapeutic range, our therapeutic index. We know what's going to happen. Well, when we give a medication, what is happening inside the body? What happens with that medication? Well, first, it absorbs. Second, it's distributed to the site of action. Third, after that, it's metabolized and broken down. It's got some active metabolites, some inactive metabolites, which is broken down. And then fourth, it is excreted by whatever route. So when we give a drug, it can be absorbed quickly or it can be absorbed slowly. So if I give just a few examples here, if I give a drug, liquid elixirs pretty quickly, suspensions pretty quickly, powders pretty quickly. Then we're going down into our capsules and our tablets and our coated tablets, and our enteric coated tablets are the slowest to absorb. So this is your ibuprofen versus like your goodies powder, BC powder, right? Powders are up here pretty quickly absorbing. Your ibuprofen, typically enterically coated tablets, are going to absorb pretty slowly. So it's kind of the marketing advertising thing that Goodies goes for, is Goodies powders. And if you don't know what that is, go and Google it, right? Goodies powder. So acts right away. That's kind of their big marketing advertising thing. Well, it acts right away because it's a powder and it just absorbs right in versus those coated tablets and those enterically coated tablets. But I have these different routes of administration, and these are going to affect absorption rates. So I've got enteral, I've got parenteral, I've got inhalation, I've got transdermal. Well, inhalation's pretty easy. I just inhale something, right? So a nebulized medication, I just inhale it. Transdermal is like a patch. You just put a patch on, you put some ointment on, it soaks in through your skin. It's transdermal. Well, what's enteral? What's parenteral? Well, enteral is, right? I don't have to create a new hole to give it, and then that's kind of the stupid way I like to explain it. Enteral is oral, it's sublingual. I can give it orally. You swallow a tablet. I can give it sublingual. You put a tablet under your tongue, and it absorbs in. But I don't have to create a whole new hole. Whole new hole. There we go. A brand new hole. There we go. A brand new hole in your body. Parenteral, I do. I have to create a new hole in your body somewhere. So I have to start an IV. I have to give you an intramuscular injection. I have to give you a shot. So enteral, give it oral, give it sublingual, give it intranasal, give it rectally. Parenteral, give it intravenous, give it intramuscular, give it subcutaneously. give it intraosseously, give it IO, right? So enteral versus parenteral. I'm giving this medication. When I'm giving this medication, do I have to create a new hole in your body? Now, distribution. I've given this medication to you, it's been absorbed. Now we have to distribute it. Well, it needs to be distributed to the site of action. So it's inside the circulatory system and distributed to your body's tissues to wherever it needs to act. Well, we've got this blood brain barrier. It protects our brain from a lot of compounds. Same thing as a placental barrier. So if a drug crosses the blood-brain barrier, we know it's going to cross this placental barrier. So some drugs do, some drugs don't. The drugs that do cross the blood-brain barrier are going to affect your brain, like opiates. Opiates are going to cross that blood-brain barrier, affect your brain, your central nervous system. So distribution, I've absorbed this drug, now it's being distributed to whatever site of action. Then after it's been distributed, it's at the site of action, it's done its thing, it's doing its thing, it's going to biotransform and metabolize. So we are converting from one chemical compound to another. We're going to have some inactive metabolites, we're going to have some active metabolites. So those active metabolites are still, well, they're still active and still they're still doing something. But we're going to have multiple sites of biotransformation, liver, kidneys, and lungs, and even the GI tract are going to be sites, common sites of biotransformation of our medications. And lastly, we are going to excrete. So we have biotransform, we have metabolize, we have all these metabolites. Well, these inactive metabolites, what's going to happen to them? We need to excrete them, we need to get rid of them. So, most commonly, we have renal excretion. We can also have this fecal excretion, this GI excretion. We can excrete via our pulmonary system. We can breathe things off. And then others, sweat, saliva, tears, breast milk, especially hair and skin. So if you're ever wondering why women who are breastfeeding can't take in certain compounds, medications, it's because they're excreting via breast milk. It's going to go straight to the baby, and things like caffeine are going to be excreted in the breast milk, and you don't want a hopped up caffeinated baby, right? So excretion happens in a number of ways, most commonly renal, but medications and just compounds, like we said, caffeine, other compounds can be excreted in other ways.